2015. Its natural history is one of slow expansion, making most patients asymptomatic. This condition can be life-threatening because of the risk of aortic dissection or rupture, which causes high mortality and morbidity in patients. The risks associated with aneurysm rupture are multifactorial, but according to most studies, aneurysm size was a very strong predictor of rupture, dissection, and mortality. One study showed that as the size of the aorta approaches 6 cm, its distensibility rapidly falls, and at this diameter, the aorta loses its elasticity and becomes a rigid tube. Considering the natural progression of aneurysm and the risk of rupture and mortality, anesthetic management of these patients present a huge challenge for the anesthesiologist. So this is a case of a 62-year-old female diagnosed with breast cancer left stage 2A. Breast mass was noted 20 years ago asymptomatic, which slowly progressed in size. Finally, the aspiration biopsy was done, which showed ductal carcinoma. Plan was to do surgery after neoadjuvant chemotherapy. However, on chest CT scan, there was an incidental finding of aortic aneurysm at the thoracic aorta, 5.95 by 5.4 cm in size. She is a known hypertensive and dyslipidemic controlled with amlodipine, atenolol, and atorvastatin. She reports to have exertional dyspnea on climbing a flight of stairs, functional status of less than 4 minutes. On physical exam, the patient was awake, not in distress, with a weight of 48 kilograms and a height of 155 cm. Blood pressure at the wards was at a range of 110 to 130 systolic and 80 to 90 diastolic. There is a note of a 3 by 4 by 4 cm solitary left breast mass, hard, fixed, with well-defined borders, erythematous, non-tender, no discharge, and no lymph nodes noted. The rest of the physical exam was unremarkable. Diagnostics were done. On CT aortogram, there was a fusiform dilation at the arch of the aorta and descending aorta, 5.5 by 6 cm and 5.5 by 5.5 cm in widest diameter respectively. Impression was aortic arch aneurysm with mural thrombus formation and dissection, Stanford type B, DeBakey type 3. A multidisciplinary discussion was done, which arrived at the decision of continuing with breast surgery. So this table shows the pros and cons of continuing with the breast surgery first versus doing the aneurysm repair first. It was chosen to do MRM first since the effectiveness of neoadjuvant chemotherapy for breast cancer can be compromised if there is a delay in surgery of longer than 60 to 90 days from day 1 of chemotherapy. Also, since the patient is asymptomatic and the size of aneurysm is borderline of the recommended size to do repair, it was decided to continue with the MRM. Patient was classified as ASA3 with ASA3 for hypertension, dyslipidemia, and dissecting aortic aneurysm. Therefore, is a high-risk patient undergoing a low-risk procedure. The anesthetic plan was to do general anesthesia using laryngeal mask airway combined with continuous thoracic epidural anesthesia. Patient was received at the operating room. Standard monitors were placed showing the following vital signs. Thoracic epidural was performed at T6 to T7 interspace. Induction of general anesthesia commenced with pre-oxygenation for 5 minutes with 100% oxygen, followed by fentanyl and propofol. Laryngeal mask airway size 3 was inserted after achieving adequate depth of anesthesia. After induction, an arterial line was placed for continuous BP monitoring. Anesthesia maintained with sevoflurane, and epidural anesthesia was started by giving 8 ml of lidocaine 2%. The surgery lasted for 2 hours, with the patient remaining hemodynamically stable. At the conclusion of the surgery, laryngeal mask airway was removed at a deep plane of anesthesia, and during emergence, increases in blood pressure was controlled with nicardipine infusion. The patient was transferred to the post-anesthesia care unit fully awake with the following vital signs. She was maintained on nicardipine infusion, and post-operative medications were ketorolac, paracetamol, and morphine sulfate via the epidural. She was eventually transferred to the general ward with stable BP and good pain control. Patient was discharged after 3 days and was advised to continue recovery and prepare for the aortic aneurysm surgery. According to the law of Laplace, wall tension is proportional to the pressure multiplied by the radius of the arterial conduit. Therefore, as the diameter of the aorta increases, wall tension increases, and this is what we can see in an aneurysm. Wall tension may be exacerbated by increases in blood pressure and will therefore increase the risk of rupture of the aneurysm. Since blood pressure is a product of the cardiac output and systemic vascular resistance, perioperative control of these hemodynamic indices is crucial in the anesthetic management and prevention of rupture. This can be attained with the preoperative use So perioperative control of these hemodynamic indices is crucial for the anesthetic management and prevention of rupture. This can be attained with the preoperative use of antihypertensive medications like ACE inhibitors and alpha and beta blockers. Intraoperatively, blood pressure can be controlled by maintaining adequate depth of anesthesia, maintenance of adequate intravascular volume, and use of vasodilators like sicardotine. Post-operatively, the most important is maintenance of adequate pain control with analgesics and local anesthetics. General anesthesia using laryngeal mask airway combined with continuous thoracic epidural anesthesia was used for this case. Using a continuous thoracic epidural anesthesia provided an effective segmental anesthesia. A block of T1 to T6 is required for breast cancer surgery. Thoracic epidural is also beneficial for its sympathetic block, attenuating the increased sympathetic activity associated with stress or surgery. Other clinical benefits include excellent post-operative analgesia with less opioid consumption, early ambulation, reduction in the cost of perioperative care, and reduction in phantom limb sensation and pain. Other regional anesthetic techniques that can be used include thoracic paravertebral block, intercostal nerve block, and pectoralis nerve block. Laryngeal mask airway was the chosen device to secure the airway since during general anesthesia, large increases in blood pressure are usually precipitated by laryngoscopy and intubation. The force applied by the laryngoscope during endotracheal intubation and the irritation caused when the tube enters the trachea can stimulate the autonomic nervous system, resulting in hemodynamic changes. Using the LMA, there is less change in hemodynamic parameters such as heart rate and blood pressure. Patient with thoracic aortic aneurysm for an elective surgery other than aneurysm repair is a challenge for anesthesiologists. The goal of maintaining hemodynamic stability and by manipulating and controlling the indices affecting pressure, flow, and volume in the aorta is of utmost importance. This can be done by continuous close monitoring, adequate blood pressure and pain control, judicious use of vasoactive drugs, and an anesthetic technique that can modify all these hemodynamic responses to surgery. Thank you.
Thank you. Okay, judges, may I ask for questions?
Okay, that was a very good management. Combine the thoracic epidural with your LMA, general anesthesia. But you might have a problem because you inserted your thoracic epidural catheter and you give a top-up dose of 8 ml after induction of general anesthesia. Is it not, would it not be better if you establish first your dermatome with your epidural before you induce the patient to sleep? As you have demonstrated there, segmental anesthesia. So you have to test the dermatome first before you, so that you will know if your epidural is effective or not, or if there is any adverse effect of your epidural.
Yes, ma'am. We only did a test dose, but we did not test the dermatomal level. Test dose if the epidural is intravascular.
Yeah, what I'm telling is, you have to test your dermatome of your epidural, do a top-up dose first before you induce your patient to sleep. That's the proper way of doing it. I agree with you, you will eliminate your sympathetic response, etc., etc. But you have to establish first your dermatome with your epidural prior to induction of your general anesthetic.
I got what Dr. Realabit is coming from, because you were very particular regarding your combined epidural and general because of the advantage of your epidural, right? So what Dr. was saying is you should have established the effectivity of your epidural first, because what you did was just a test dose. What if the epidural didn't work, or, you know, I mean, there's always a failure sometimes, a certain percentage of failure with your epidural. So since you really need that epidural for this kind of patient because of the aneurysm, might as well have it tested first before you put the patient to sleep.
You're very lucky. Hindi nag-rupture yung aneurysm. Because if I were to do this, I would prepare also for a possible thoracic aneurysm, rupture. So you should have to prepare blood, should have your surgeons there. So you were very lucky.
Heart center dapat. Okay.
All right, thank you. That's a wrap. Thank you to all our presenters for today. That was a very fruitful and informative